Well, it's my great pleasure and honor to be here today. Give the opening speech. Couple of reasons why I'm really excited. First of all, it's Taiwan, and I think nothing compares to the hospitality of Taiwanese people. Just as a side story, last year I made a few friends at the hackathon, and so two of them, Pei Chen and Su Sheng, they took me on a road trip around the island in their car during the whole day after the event. So, and we're still in contact. We're still good friends. So I mean, I've been to a lot of these conferences and events, and it just doesn't happen anywhere else. So, well, I mean, I'm really grateful. Second reason why I'm excited is because the research I'm going to present to you today is going to be published next Monday in a leading journal. I'm not allowed to say the title. Shabir did, so if you heard it, good for you, but there's an embargo. They have a really strict policy that you're not allowed to say which journal it's published in, but it's the best journal for preclinical medicine in the world, and it has an impact factor above 30, so you can narrow it down. Thank you. So reinforcement learning in healthcare. In a nutshell, this is a branch of machine learning that can be used to develop decision support systems, and I think this is why it's an exciting field, because beyond prediction, we can start working on actually influencing doctors when they make decisions using AI, using computerized systems to help doctors making better decisions to treat patients. A bit like self-driving cars, or things as simple as automatic translation. This helps us in our day-to-day life, but this is not about getting from A to B. This is about saving lives and improving cost effectiveness of the healthcare systems. So potentially something meaningful in a few years. And as a last remark, this is a project I started 4 years ago at a datathon in London, and we won first prize with this project. So maybe in 4 years you'll have a paper in a great international journal with the project you're going to start working on today, and probably less than 4 years, because you're probably more clever than me. All right, let's get started. Why do I think it's important to work on health data analytics, especially in intensive care? That's my specialty. Well, I think it's a great way to generate new medical evidence. We know about the limits. Peggy told us about the limits of randomized controlled trials. Very often, the results you get from randomized controlled trials are not applicable to a particular patient you have in front of you. So this is simply another approach to get answers to clinically relevant questions. And why the intensive care environment? Well, that's easy. First of all, you need a lot of data to do data analytics, and ICU is one of the few very data-intensive environments in the hospital. There are a few others, and also I think it's, of course, very important to focus on diseases and issues that are associated with high morbidity, high mortality, and also high expenditures, and try to improve this. So this talk is not going to be too technical, hopefully, but there's the way I organized it is we're going to talk about the problem first. What is sepsis, and what's the key difficulty in treating patients with sepsis? Then we'll talk a bit about machine learning and reinforcement learning, because maybe a few of you are not too familiar with this concept, and then I'll show you the solution that I've developed. So sepsis may not be very well known by the general public, but it's a huge problem. It's infectious diseases are the second or the third leading cause of death worldwide, depending on what numbers you look at. So after cancer and cardiovascular diseases, infectious diseases comes probably third. Over 25 million people may be affected by sepsis per year. I think it's 6 million deaths. It's the main cause of mortality in hospitals, main cause of mortality in the intensive care unit. Some reports have said that it was the most expensive condition treated in hospitals. And a key difficulty, we'll talk about it in more detail, in treating sepsis is how do we manage intravenous fluids and vasopressors. If you don't know what that is, don't worry, I'll be explaining. But this is a key difficulty in treating those people. It's a global health issue. There's very huge international endeavors trying to tackle this problem. Things that you may have heard about, such as the World Sepsis Day in September, the Surviving Sepsis campaign. So international experts are sitting together, have been sitting together for decades trying to address the problem of sepsis. The physiopathology of sepsis, the physiology of sepsis is at least at a superficial level, it's not too complicated. It starts with bacteria entering the bloodstream, and then cells from the immune system react with these bacteria, macrophages, neutrophils. They react with these bacteria. They start releasing lots of inflammatory molecules, cytokines, and so on. Different pathways are activated, and they all lead to a few things. Activation of the coagulation at the endothelium level, vasodilation, so the blood vessels become loose, and the third one is increased permeability, so the blood vessels become leaky, and fluids goes from inside the bloodstream to the interstitium, and all of this basically leads to organ damage, and if it's left untreated, it leads to death. Certainly before the advent of antibiotics, infectious diseases were the leading cause of death in the world. Most people would die from pneumonia, much more than myocardial infarctions or cancer. Before the advent of antibiotics, that's my point. So I told you about the leak of the capillaries, that they become leaky, and the fact that those vessels become loose. And basically what this leads to is absolute and relative hypovolemia. It means low circulating blood volume. And I'll try to explain this in a very, very simplified way, but if you think about a patient starting with normal blood vessels and a normal blood volume, what vasodilation does, if the vessels become loose, then the volume of blood relatively to the container is too low. So this is relative hypovolemia. But also if the patient loses fluid, he gets absolute hypovolemia. So these two features are present in sepsis. It's a key feature of it's a key aspect of sepsis that leads to organ damage, as we said, and eventually death. So what we can do, again in a simplistic way, is first of all give those patients vasopressors. So these are drugs that will squeeze the blood vessels, in particular the arteries, but also the veins. Squeeze the blood vessel to restore their normal diameter. And we can also, of course, give those patients intravenous fluids directly inside the vein. And the concept behind this, obviously, is to restore the adequate blood volume. Sepsis is much more complicated than this. There's dysregulations and anomalies at the cellular level that are not corrected by these maneuvers, but it is still important to restore an adequate blood volume to improve tissue perfusion. So if we want to really simplify the way we treat sepsis as doctors, there's three aspects probably. We need to control the source of infection, meaning we need to give our patients antibiotics. We need to drain an abscess very quickly. This is very clear. Correct hypovolemia, vasoplegia is very difficult. I'll talk about it in a bit more detail. And then we need to treat secondary complications. So if the sepsis has been ongoing for too long, those patients have renal failure, they can have cardiac failure, respiratory failure, and so on. So these need to be treated as well. But this we know how to do. So I would argue that the key difficulty in sepsis treatment is correcting hypovolemia and vasoplegia. The difficulty is that it is a tricky question. There's a relationship. This is not my slide, but there's a relationship between the amount of fluid you're going to give to a patient and the level of organ failure and complications. And basically, if the patient has too little fluid or too much fluid, complications will happen. And there's a sweet spot in the middle where tissue perfusion is optimal. But the difficulty is that this point is we don't know where it is. It's dynamic, it's different in every patient, and it's different across time. It changes. So lots of questions remain unanswered in sepsis. How much fluid do we give to those patients? When is the right time to start vasopressors? What is the right balance between fluids and vasopressors? You can choose to give lots of fluid and no vasopressor, or lots of vasopressor and no fluid. Basically, what's the right decision? We don't know. And what parameters do you target when you resuscitate those patients? Again, this is not fully known. Most of the guidelines rely on basically expert-defined resuscitation parameters and resuscitation targets. Until recently, we had something called the early goal-directed therapy. So this was the concept that with a very protocolized approach, we could improve the outcomes of sepsis. So the details don't matter, but basically you had to follow a particular procedure by that is basically quite invasive in the sense that all the patients needed a central line and so on, but that's not the key problem. The key problem is that this approach led to giving more fluid, more vasopressors, more transfusion to the patient, so more interventions that potentially have their side effects. That it relied on targets and endpoints that were defined by experts, but partially arbitrarily. And the other problem, I would argue, it is whichever way you look at it, it's a one-size-fits-all approach. And in particular, if you still look at the Surviving Sepsis Campaign guidelines, they say that all patients should receive 30 mL per kilo of intravenous fluids, I think within the first hour of admission to the emergency department, which physiologically speaking, medically speaking, doesn't make sense. Why would all the patients need 30 mL per kilo exactly of fluids? It's going to be too much for some patients, it's going to be too little for other patients. When correcting hypovolemia, I'm going to go quickly here, but basically there is evidence that if this is showing you the fluid balance of patients, so the difference between intake and output, and this is days after sepsis. And what you see is that the patients who here in the blue curve have a sustained positive fluid balance, they survive less than the patients who achieve a neutral fluid balance by day 4 or day 5. So there is evidence that if you give too much fluid to the patients, this is adjusting for severity. If you give too much fluids to the patients, there is a chance that they will survive less. And here, this is showing you the time of initiation of vasopressors, so it's in hours, after the onset of hypotension, so this is in septic shock, and this is showing you the mortality. And what you see is the longer you wait to start vasopressors when the patient is hypotensive, the more the patients died. So maybe we should be starting vasopressors early and earlier than the Surviving Sepsis Campaign recommends if we wanted to lower mortality. So this goes against some of the recommendation of the Surviving Sepsis Campaign that say that you need to give fluid, and then if the patient is still hypotensive, then you can start vasopressors. So the current status is that several randomized controlled trials have confirmed that the early goal-directed therapy was not optimal, and now it's been dismissed. And some authors have talked about the demise of the EGDT. So now we're left with very little guidance as to how to treat those patients, and certainly there is no real-time decision support system that would allow us to deliver what we've been looking for, this precision medicine, this idea that we're going to have a system that's going to give us the right answer for a particular patient at a particular time t. This doesn't exist. Right. Now the interesting part, so we're going to talk about machine learning. What is machine learning? There's a very simple way to look at it, is that machine learning is about learning from data, learning anything, learning to predict, learning to make better decisions. And to me, at least in my simple mind, machine learning is the same thing as AI. It's just a synonym. Machine learning has basically 3 pillars. One is supervised learning, one is unsupervised learning, and the third one is reinforcement learning. And they all have different methods and different objectives. Supervised learning is about learning the relationship between input data and output data that is labeled. So you know, for example, if you want to predict mortality, when you train the model, you know which patient survived, which patient died. This is why it's called supervised, because you have the label on the patient. Supervised learning has two main sub-branches: regression and classification. Regression is when you want to predict an outcome. It's when the y is continuous. Classification is when the y is discrete, so either binary or categorical. Unsupervised learning is about learning the structure in the data. So you don't provide any label. You feed the data set in an algorithm that's going to try to identify, oh, are there particular groups of patients that match? What is the structure of the data? What can we learn by simply plotting it or lowering the dimensions? So clustering, dimensionality reductions are classical algorithms of unsupervised learning. And then reinforcement learning is about learning an optimal strategy, and we'll be talking about this in more detail. A very quick example of supervised learning in healthcare. This was published earlier last year in Nature. You probably have seen this paper. They showed that by developing an algorithm, they were able to categorize, to classify skin lesion as to cancerous or non-cancerous types. And this has been developed into an app. So now you can take pictures of any skin lesion you have on your smartphone, feed it into this algorithm. It's going to tell you the likelihood that this is cancer or not cancer. Again, a great paper, groundbreaking, eye-opening, but this is still only, so to speak, a computer vision task. Another example of supervised learning. Another example of a classification algorithm, and we can go much further than this, and this is what I'll be presenting in the remaining of this talk. So, well, let's talk about reinforcement learning. The idea, as I said, is to learn an optimal strategy, and I would argue that this is more complex than prediction tasks. I want to give you a bit of an intuition behind reinforcement learning. So if you think about a rat in a maze, the rat is going to be the agent in reinforcement learning. The maze is the environment. The agent can be in different states. So every single cell of the maze is a state in which the agent can be. In every state, the agent has the choice to take different decisions. It can decide to go up, left, down, or right. So there is a set of actions that are available to the agent at any time point. And the objective of the agent is to maximize a reward. So in this example, the rat wants to get to the cheese as often as possible and wants to avoid being electrocuted as often as possible. So there is a reward associated with being in this state. There is a penalty associated with being in this particular state. And the objective of the agent, the objective of the reinforcement learning agent, is to find what is the best action in every state of the system in order to maximize reward in the long term. So you can imagine you take the same rat and you put the rat 1,000 times at the beginning of this maze, and you let him roam. He's going to start trying actions at random initially, and basically finding the cheese or being electrocuted. And after 1,000 times, it's very likely that the rat will have figured out that the best path is probably around this way, and maybe around here, but it's risky because if he gets it wrong here, he's going to get electrocuted. So that's the intuition behind reinforcement learning. You learn by trial and error a set of optimal decisions. And in a very simplistic way, this is the same thing as medicine. So our patient can be in different states, in different clinical states, and the objective of the doctor is to send the patient home as often as possible and avoid the cemetery, right? This is why we spend 15 years at university, to make the right decisions in every state of the system in order to send the patient home, improve survival. Reinforcement learning is now a buzzword, I think, at least in the computer science world. There has been a lot of groundbreaking papers. I'll show you a few more examples in the next slide. But arguably, it started with this paper. This is published in Nature 2015 by a team at DeepMind in London. And what they did is develop the concept of deep reinforcement learning. Their approach was pixel to action. So they developed an agent that was able to play Atari games from pixel without any human input, and would after training, after millions of hours of simulated training, was able to outperform any human player at most Atari games. So this was a groundbreaking paper, and what you see here, this is the value of being in a particular state for 4 examples, and you see here that the value, for example, here when the ball is this is what's the name of this game in English? Breakout. Yeah. So the goal is to destroy all the blocks on the screen by having a ball bounce back and forth. So you control this paddle. I mean, I'm just talking to the young audience because I'm sure you've never seen this game, but to me this is yeah. I mean, I can say this is my childhood. So I did have this game in black and white on a Game Boy back in the early 90s. So what you see here is the state here of this ball is less good than this ball here. So the value of being in state 1 is lower than the value in being in state 4. This is what this figure is showing. Since this paper, that was 3 years ago, lots and lots of progress have been made in reinforcement learning, and you've heard of DeepMind beating what was his name? I forgot, but the best player in the world at Go. The game of Go was the Korean, yeah. Okay. The game of Go was considered to be unbreakable by computers until this happened, and since then they've used the same AI they've applied it to the game of chess, and similar algorithms now are able to play real-time FPS games. So this is Doom. I don't know if you've seen this game. Again, it's a game from the 90s, but now reinforcement learning based AI systems are able to play really complex games such as Doom, pixel to action again. So this is not about feeding information about the behind the scenes. This is putting a computer screen in front of a camera and having the computer figure out where he is, what he needs to do in order to win the game. It's extremely complicated. And even more complicated now, we're approaching the point that where reinforcement learning agents will be able to play RPG game and strategy games. So this is a really exciting concept of hierarchical reinforcement learning, where you have agents learning a subtask, and then you have an overarching reinforcement learning agent directing the sub-agents. So for example, you have one agent learning to build soldiers, one agent learning to collect minerals and gas. This is StarCraft 2. And then you have another agent that's going to control those sub-agents in the idea of hierarchical reinforcement learning. So there is a hierarchy of agents. Extremely complex to train, but we're getting there. And we could imagine that this could be applied to healthcare as well. In intensive care, we optimize nutrition, we optimize sedation, we optimize pain control, we optimize the infectious status, antibiotics, we optimize electrolytes, we optimize renal function. All of this a bit separately, so we could imagine using this approach in intensive care or any area of medicine. But why is medicine harder than this? Why have we not seen hundreds of papers about using reinforcement learning in medicine? Well, there's a few reasons. First of all, it's a high-risk environment. You don't want to take the risk to deploy an algorithm that will harm people, even though I would argue that doctors harm people a lot. a lot. I mean, I don't want to be too provocative, but very often we don't know what we're doing, especially in sepsis. When we prescribe fluids or vasopressors to patients, we might as well flip a coin. And this has been shown. Where, for example, using clinical examination, if you want to determine whether a patient needs fluid or not by physical examination, the AUC is 0.5. You can flip a coin, and it's gonna be the same. It's gonna be the same effect of having a doctor try to do it. In medicine, we have a limited amount of training data, and I think this is where endeavors like what you are doing in Taiwan or what Mimic is doing is very important. So make the data available, make it open. The environment is not fully specified. This is another very difficult point. So when you look here, this environment is fully specified. At any point in time, you know exactly which state you are in, what action you need to make in order to win the game. In medicine, it's very different. What we have is basically we're looking through a keyhole inside the physiology. We have vital signs, we have lab values, but this is not the ground truth. This is not what's happening at the cellular, molecular level. So the environment of a human body is not fully specified, and this is why it's very difficult. This is one of the reasons. Another one, it's impossible to learn by trial and error, right? We cannot just connect computers to people and be like, oh, just try. Oh, oops, the patient died. That was the wrong decision. Get another patient in. So this is a big difference with what they do in computer science. Here is an example of this is called a mountain car problem. It's about training a car to climb a mountain without overshooting. It's a classical task in reinforcement learning papers. But what you see here, they try. So this is the value of a particular policy. This is the value of a strategy, and they try 20,000 times to drive this car up the hill. And you can imagine that most of these episodes end up with the car crashing. Because they have to learn to drive this car. So learning by trial and error is very useful in computer science problem. It's impossible, completely impossible in healthcare. Saying the same thing, we don't have a simulator. We don't have a simulator that would be accurate enough to test those strategies. So if we were to try to develop reinforcement learning for healthcare, I think it's good to take a step back and think about how do doctors think. What is the cognitive process that goes in the mind of a doctor when treating a patient? So what we do is we use different things. We use the data from a new patient, the patient coming in the emergency department. So we collect data about this patient, and then we use two things: our theoretical medical knowledge and our clinical experience, and we integrate all of this information to make a decision. And then we treat this patient as best as we think. And the problem is this is a very flawed approach. We have lots of cognitive biases, right? You'll hear countless stories of doctors who have had one side effect, let's say one anaphylactic reaction with one drug. They're very unlikely to use this drug ever again on their patients, even if it would have been the best possible drug. Very often we lack models to understand our patients. Sometimes we lack theoretical knowledge. I don't know as much as a neurosurgeon on neurosurgery. I don't know as much as a cardiologist on heart disease. No doctors knows everything. Also, we forget things. You may have seen a very similar case a few years ago, but you may have forgotten what happened to these patients. Sometimes we get the diagnosis wrong, and probably more often than we think. And also there's lots of practice variation. So this whole cognitive process in medicine is highly flawed, just because we're humans and because the task is very difficult. So if we were to imagine the perfect medical system, the perfect doctor, what would it be? There's possibly two ways to look at it. Either we have complete understanding, complete knowledge about human physiology, human diseases, what all the treatments available, and what would be the most optimal one. So this is sort of a godlike approach where you would know exactly, you would know everything. So I hope you agree with me that this is impossible. The other possibility maybe would be to have knowledge about a vast number of similar patients that similar to the patient in front of you in the emergency department. If you knew about 1,000, 10,000, 100,000 people that were very, very similar to this patient in front of you, if you knew exactly what treatment they received at any point in time and what was the outcome, maybe that would give you some information about what is the most optimal decision for this particular patient in front of you. And this is the intuition behind reinforcement learning. So you can think about having a cloud of patients that are similar to your new patient, and then you know exactly who survived, who died, what treatment they received, and then you have this new patient coming in, is in front of you. You need to treat this patient. By looking at all those similar patients, maybe this will give you some intuition, or at least reduce the uncertainty around what is the most optimal treatment for this new patient. This is the intuition, the field behind using reinforcement learning. We can express medical decision as a reinforcement learning problem. You remember we talked about the rat in the maze. So this time it's a physician. The doctor is acting on the environment of the patient. The patient can be in different clinical states, and the physician is going to follow a policy. Is going to take actions, particular actions, given the state of the patient. The patient is going to react by switching state, getting better, getting worse, and if the new clinical state is better than the previous one, the doctor is going to get a reward. If your patient survives, you get a reward, at least in principle. And any action that led to a reward is reinforced. This is why it's called reinforcement learning. Positive actions are reinforced. Negative actions are impeded. Yeah, penalized. Thank you. So if we had a framework like this, we could ask two questions. How good is the policy of physicians? And of course, can we find an optimal policy? We use the Greek letter pi, so the optimal policy pi star that would maximize survival. The simplest framework to apply reinforcement learning is the Markov decision process. So there's lots of options of different frameworks, and it's very much an ongoing field of research. But the simpler one, and you know all the elements of a Markov decision process, even without realizing. But what this is good for is problems involving complex stochastic, so meaning partially random, like doctors. Doctors are random, and dynamic, so it changes in time. So at least on the paper, it looks like the right model for our problem. If you want to define an MDP, you need to define states, you need to define actions. So we talked about this, right? These are all the clinical states that the patient can be in. The actions is, in our case, prescriptions of fluids and vasopressors, because we said this was the key clinical problem. Then you need to define a transition matrix. So this basically characterizes the dynamics of patients moving from one state to the next. What is the probability to go from state 1 to state 2 given that a particular action was taken? And then you need to define reward and penalty. So in my example, that was easy. Survival is reward. Death is a penalty. Without pun. The data that I used in my research, so two data sets. I used Mimic for model development. Mimic has about 60,000 admissions. With all the exclusion, I ended up with nearly 18,000 patients with sepsis in the development data set. And then for validation, I used the data set from Philips. So not the EICU CRD on which we will be working this weekend, because this is the open Philips dataset. I used the full Philips dataset when I was at MIT. So to start with, this is 3.3 million patients, and then you need to exclude lots of patients where the data is simply not usable. And I ended up with 80,000 patients from 120 ICUs in the US. This is all US data. So I included patients with sepsis, unsurprisingly, and I extracted time series of patient data from those two databases. And then this was used, altogether it's about 700 years of data. So you can imagine this is way more than any human doctor would be able to remember, because we're talking about, remember, at any point in time, all those patients, nearly 100,000 patients, exactly what was every single one of their vital signs, lab values, what treatment they received, and so on, for 700 years. Impossible for a human brain. The approach we took is that, so I used the MIMIC dataset to define the elements of the MDP. Okay, now you know everything, the states, the actions, the reward, the transition matrix. This was all defined using MIMIC. And then I applied 2 reinforcement learning algorithms. One, to evaluate the policy of the doctors. What is the value of the actions taken by actual doctors in the MIMIC dataset? And then we identify an optimal policy. We estimated an optimal policy. And then this was validated on another part of MIMIC and then tested on the EICU data. Without going into too much detail, but maybe, how much time do I have? How much more time? I think 10 minutes? Okay, I'll move on. This is the result. So that's the last part. So I think we're good in 10 minutes. Here I'm showing you the calibration of the model. So we try to learn the value of actions taken by doctors. What you see here, so the value of actions can go from -100 if it's a very bad decision to +100 if it's the most perfect decision and it leads to survival all the time. And what you see is the model is quite well calibrated. That's the risk of mortality of patients, and you see this homogeneous decreasing relationship between the actions taken by doctors and the risk of mortality. So this is what we wanted. And if you look at the average return per patient, showing survivors in blue and patients who died in red, you see that the patients who have mostly optimal actions with high return, they do survive. If you get it wrong all the time, if you're a poor performer, let's say the average return of your actions is always negative, the patients are going to die all the time. So again, this is showing you good model calibration. How optimal do you need to be? That's an interesting question. Does it matter if you take the second most optimal action or not? Well, the answer is probably yes. This is showing you the average patient mortality depending on whether you took the best optimal action, the second best, third best, fourth best, and so on. And what you see is even if you take only the second best optimal action, the mortality is higher. So it does matter to be optimal. Next, we compared the values of the two policies. So now we have two policies, if you follow. One is the doctor's policy, the actual doctor's policy. One is the policy suggested by the AI system. And what I'm showing you on this slide is a comparison between the two policies. So this is the average value of the policy of doctors on the x-axis. On the y-axis, the average value of the AI policy. So anything above the diagonal means that the AI policy has a higher value than the doctors. You see, for example, here, I think it's about 85 average value for the AI, and it's about 55 or 60, if I'm not wrong, for the clinicians. So nearly 100% of the time, there are actions that are more optimal than what the doctors did. There are options that could have led to better patient survival, nearly 100% of the time. And the AI policy was able to identify those actions. The next thing we can do, and that's more of a qualitative analysis, we can compare what the doctors did and what the AI would have done in terms of dose of drugs. So what you see on the left is the doctors, on the right is the AI policy, And this is showing you the dose of vasopressors, the dose of IV fluids. I don't know if you guys can see my pointer, but on the left you have dose of vasopressors. These are micrograms per kilo per minute, and dose of intravenous fluids. These are milliliters per 4 hours. So it's just a convention coming from the data. But what you see is doctors, they gave vasopressors to about 10% of their patients, 10-15%. This would have been about 30% according to the AI, so twice as many patients would have been on vasopressors according to the AI system. And then you see that many patients are on high doses of fluids here. And it's not the case for the AI. The AI says back off on the fluid and start vasopressors potentially earlier and in more patients. So if you remember what we said about some of the literature saying that maybe better survival would be achieved if patients received less fluid and more vasopressors. This is in keeping with the results of my analysis. Next point is, how do we know that the suggested doses are optimal? This is a very difficult question because obviously it's all retrospective. We haven't done any clinical trial yet, but we can, and obviously it's impossible to know the action, to know the outcome of an action that was never taken. So what I did is I looked at the difference between the dose suggested and the dose given to the patients. And if this difference is 0, it means that the patients in the past received the suggested dose. And this is what you see here on this slide. On the left, intravenous fluids. On the right, vasopressors. The x-axis is the difference. It's not easy to follow, but it's the difference between the dose given and the dose recommended. So if the difference is 0, those patients receive the suggested dose, and you see that the mortality is the lowest at the point 0 for vasopressors and intravenous fluids. And then the further away you go from 0, the more the patients died. So basically, if we say it in a crude way, the more the physicians got it wrong, the more the patients died. The last aspect is about interpretability. This is a very challenging area of machine learning and deep learning. People will want to know why the algorithm says something. Why do I need to start vasopressors? Why do I need to stop intravenous fluids? Why would I trust your AI system? What's happening under the hood? Can you explain this to me? And this is a very difficult area because obviously very often we cannot explain. We don't know why an AI system is telling you to do something. If you think about the dermatology paper on skin cancer, we don't know why a particular lesion is going to be classified as cancerous or non-cancerous. Okay, so it's the same thing here. But it doesn't mean it's not accurate. It just means that our brain is too limited to apprehend the explanation, because it's thousands and millions of neurons connected with different weights. It's just impossible for us to apprehend this. So what I've done here is evaluate the relative importance of all the model parameters when deciding to prescribe a particular drug or not. So, and I compared doctors and AI. So basically, without going into the detail, but you can estimate the relative importance of all the 50 parameters of the model. And what you see is that doctors, when deciding to start vasopressors, for example, they look at SOFA, which is a severity score. They look at blood pressure, the Glasgow Coma Scale, the fluid balance, the renal function, and so on. So these are, if you're a clinician, these are clinically meaningful parameters when deciding whether a patient needs vasopressors or not. And if you look at what the AI did, it's very similar. So the parameters that are the most important to the AI system are also clinically relevant. It's not picking some random signal from the patient's, I don't know, from the patient's calcium or gender. These don't matter in the decision, but the parameters that matter appear at the top of the list, and they are clinically relevant. So it's an important it's an important aspect that suggests that the AI is doing something meaningful. Okay, that was my last slide. So I hope I convinced you that the current way we treat sepsis is suboptimal, that by using reinforcement learning we could potentially do better, we could improve the decision processes. Model evaluation, I didn't even talk about this, but this was extremely complicated to evaluate the model, to give some confidence that the new model is going to be safer than humans. Really a key aspect of the research, to evaluate this model. Interpreting the model is also difficult. Knowing what's happening under the hood. And finally, this particular question that we've addressed is interesting, but there's lots and lots of different questions that could be addressed with reinforcement learning. But the framework is transferable to other domains. Thank you. Don't hesitate. Send me an email or a message on Twitter if you want to discuss this or anything else. Thank you.
Maybe 2 questions. If anyone have 1 or 2 questions? You have one? Okay.
Thank you for a wonderful presentation. The only one question I want to ask was, you train data with mimics with 17K patients and validate with EICU with 80K patients. But usually we do turn like we train the model with large number and validate with low number.
No, absolutely. That's a very valid point. So the reason is very practical. Is that I had access to Mimic much earlier. So the model was developed on Mimic. But if I was to repeat it, if I had both data sets available from the start, absolutely I would train it on EICU, because 80,000 patients give you much more variability, much more robustness. That the model is going to be able to perform better on a wider variety of patients and clinical situations. You're absolutely right.
Thank you for an excellent, very informative presentation. This may be a stupid question to ask. With so many variables, so many parameters in the ICU, in your opinion, what would be the minimum number required for training so that you would get clinically acceptable results? Is it 20,000? Is it 40,000? Is it 80,000? And how do you decide on what this number is?
So you're talking about number of patients to train a model?
Yeah, for the number of data sets, data from patients. And you showed 80,000 and 20,000.
Yeah.
So what would be the absolute minimum to give you reliable results?
Yeah. So there's not going to be a one number answer. I think there's going to be a continuum between. So the higher the number of patients, the more confident you're going to be in the results.
That's true, but what would be the absolute minimum? You wouldn't consider 5,000. You wouldn't consider 15,000. Give me some number, just to have an idea.
Yeah, you need several thousands for sure. I would probably 5 to 10,000 would be a minimum. But maybe I'm wrong. Maybe you need less than this. But there are ways to figure out. So when you assess the value of the policy, you get a confidence interval, a confidence bounds around the value of your new policy. So you're going to see this confidence interval getting bigger and bigger as you decrease the number of patients. So there is a cutoff at which you will be able to say, okay, this is not enough patients. I need more patients to be confident that the model is going to be performing well.
Okay, can I? Yeah. Thank you, Matthieu, for a great talk. You mentioned about 44 variables, right? Since we're in this AIoT topic, if there's any IoT that you can add to the patient that would actually increase the accuracy of the prediction for patient with sepsis or management of the patient, what would you do?
I mean, it's an area of research, right? What new parameters can we gather about our patients? It's not very common to use wearables, for example, in intensive care because people are sedated asleep. Do you have any thought? I'm sure. I mean, obviously we're talking about genomics and so on, but we're moving away from
For
IoT.
example, heart variability skin conductivity, maybe EEG.
Yeah.
Would that actually help your problem?
I'm sure it would, because a key aspect is about precisely defining the clinical states of the patients, and the more information you have about the patient, the more precise you're going to be. So absolutely, heart rate variability and so on. Clearly, I know it's linked to basically everything. So it would be very valuable to add this information.
All right, thank you.
All right, thank you, Dr. Komorowski. This is groundbreaking, truly. I think that this very similar approaches will be applied to a wide range of problems. So I think this is very interesting work. So our next speaker is going to, and our final speaker is here, but we're going to stall. Okay, how about one more question? That's a good way to stall.
Sorry, you may already answer the question, but I didn't catch. So still in the reinforcement learning, how you try and error, like you say, the patient you cannot try in dangerous condition, and so how you answer, how you do your
Yeah. So instead of taking the same virtual car and running 20,000 simulations, you take 20,000 real patients. You take a big database with 20,000 people, real people in it, and you basically you need more data, because some patients. So if let's say you have a group of 1,000 patients that are very similar, 500 got dose A, 500 got dose B of treatment, and those who got the dose A survived, those who got the dose B died. And basically this is the intuition that by taking large amount of patients, you look at the practice variability, the variability in what the doctors did, and this will give you the answer. This is where the answer is.
So that is how you do it.
Yeah.
Then I will raise two questions. So one is you never have enough parameters.
Yeah.
Each patient is different.
Yeah.
So maybe you have 100, maybe you need 200 more. And second question is real time, like emergency room, ICU, emergency, that you need very critical.
Yeah.
So these two will
Yeah.
up to that.
Yeah, you're right. So obviously, the more data you have about the patient, the more precise the model is going to be. So there is a point under.
You more patient is mean it's more precise on the certain number of parameter and certain of diagnostic, but that is not my question.
Oh, you're talking about.
There will be some variation in each patient, and you maybe need more parameter like their behavior, maybe some other living.
I forgot who said this, but maybe a mathematician. He said every model is false, but some of them are useful. So this is a model. It's a simplification of reality, but maybe it's useful. But by definition, every modeling technique is false because it's not reality. So obviously it's not perfect. I'm not saying it's perfect. It is a simplification, and we will need prospective validation, clinical trials. Yeah, absolutely. You're right.
Okay, thank you.